So is my screen visible, Yogesh?
Yes, yes.
Okay, great. So in fact, good evening, everybody. In fact, in another episode of Surgical Academia, we have an eminent speaker, Professor Yogesh Basist, who in fact by heart is an Indian, but by nationality is a German now. For last 36 years, this young man is staying in Germany. Though he was born in India, but his schooling and medical education, everything were in Germany. So it's great to have you, friend, today on board. And he is the Deputy Chief and Senior Consultant in Department of General, Visceral and Thoracic Surgery in Asklepios Hospital in Germany. He has a long history of professional education. He has specialization more in surgical oncology, and he is a prolific esophageal and gastric cancer surgeon. Professional career dates back with many accolades. Has 140 original peer-reviewed papers, 115 PubMed listed chapters. He has editorial responsibilities in 4 international journals. So Yogesh has gone quite ahead in the academic front, as well as he's a fantastic surgeon. It's good to have you with us today evening, Yogesh, and it's good to get connected. Maybe a year back, I got connected with Yogesh, and it was fantastic. Yogesh has a great experience in upper GI surgery, more so in malignancy surgery. He is also into many kind of administrative activities in many associations, and is board in the board of directors in many other scenarios. And so in this connection, next week we'll have Professor Yuri Novisky from Columbia University in US. We'll be talking on TAR, the man who in fact gave the idea of TAR. And just 3rd of July, we'll have Professor Adarsh Chaudhary in this panel. So thank you, everybody. In fact, the screen and here, everything is yours. This is coming up on the 30th of July with Desarda and Professor Desarda and Professor Rajiv Sinha. Whether open groin hernia is going to stay or die out. So anyway, thank you, everybody. And let's have the screen and here, everything is now yours. Yogesh, you can please go ahead. Let me first unshare my screen. Yeah.
So now I have to. Is it working?
Yeah.
Okay. Many thanks, Manoj, for the invitation to speak in this on this celebrated platform, and I am quite keen and also astonished to see so many people on the online meeting at this time. I guess most of you are from India right now. It must be quite late in the evening. So my whole education has been in Germany, and I did specialize in hepatobiliary and upper GI surgery. But the upper GI surgery is my main interest, and I am also at the board of European Board of Surgery, also as examiner. So if any one of you is keen to take the examination, is welcome to contact me with his curriculum, and I shall be helpful in whatever manner it is possible. So this talk will cover an overview of general practice in gastric cancer, especially in Europe, but also it's almost the same in the United States and Canada. We will talk mainly about resectable disease. We will have a few anatomical specifications outlined here, and it should inspire you to have a slightly critical look at the so-called evidence for multimodal approach that is nowadays promoted in upper GI malignancies. What this talk will not cover is about the development and progression of gastric cancer, and we will just speak a little about the metastatic disease, and we will not go into depth about the various regimens of systemic chemotherapy, and we will not also go in depth into survival analysis regarding time to progression, disease-specific survival, and also in terms of overall survival related to a specific therapy. But this talk should And it is very important to outline this. My intention is not to demonize a multimodal approach or question the efficacy of a specific treatment, especially the systemic therapy, but rather we as a surgeon should recall the importance of surgical standards, especially nowadays where the general notion in treatment of malignancy, especially carcinoma, what I have the impression in Europe and also in Northern America, is that systemic therapy is more valuable, and in few cases surgery can be done. And the young surgeons should be motivated by this talk, hopefully, to have a closer look on the so-called evidence that is the basis for the multimodal approach nowadays, and which is the main reason for the development and also promotion of the national guidelines in various European countries. So when we talk about guidelines, we have to recall that from all the research that is available in literature, we have some evidence. Yeah, the best evidence nowadays, what we consider, are from randomized controlled trials, but we don't have evidence for everything. So in that place is often filled with so-called expert consensus. So there are experts who are working on this field for decades, and they have a certain opinion, and this together makes up the guideline basis. But if we go into depth, and this is not specific for gastric cancer surgery in Germany, if we check the national guidelines for any disease, yeah, not even malignancy, but also non-malignant diseases, we can see that the evidence within these guidelines is, the percentage is very low. And for gastric cancer, it is even less than 18%. So the data, the statements that is promote in these guidelines are not all or not at all based on randomized controlled trials. Majority of it is just the opinion of few experts. When we talk about upper GI surgery, first of all, we have to consider that we have a different anatomical composition when we talk about the esophagus or the or the stomach, and especially the junction is very specific, and it is neither to correlate with the drainage and blood supply of the stomach and not also of the esophagus. Then we have various type of histology available here, and also the different carcinomas have different histology, and the lymphatic drainage can vary very much between the thoracic compartment and abdominal compartment. On the other hand, we of course have various approaches regarding the surgical approach in terms of lymphadenectomy, total gastrectomy, partial resection. And nowadays, as the multimodal approach is promoted, they are all not a single approach that is promoted. We have the setting of a neoadjuvant therapy, a perioperative therapy, and in some case, also an adjuvant setting. So resectable disease, it's quite clear. It's an early cancer. Yeah? We will talk about that a little bit later. But in Europe, the early cancer is primarily the domain of the endoscopist. It is mainly treated by the gastroenterologist by endoscopic resection. And in few cases where the diagnostic have been poor or where the judgment initially was not good enough, a step-up approach followed by a classical resection is possible. Yeah? And according to the underlying disease, an additional therapy may be required. The locally advanced cases, these are the majority of the cases where primary surgery is the main approach. Nowadays, a multimodal therapy is recommended, either in a neoadjuvant setting or a perioperative setting. Endoscopic therapy, you all are aware of these pictures. If we have a submucosal invasion of more than 1/3, then endoscopic therapy is not possible or should not be recommended. Why? Because, I'm sorry, I have to go. because of the rate of lymphatic invasion that correlates with the depth of submucosal invasion. Endoscopic techniques, just for the sake of complete presentation here, we have the endoscopic mucosal resection and we have the endoscopic submucosal dissection. And the disadvantage of the mucosal resection is, of course, especially at the lateral borders, we cannot histologically prove if we truly have a R0 resection. EST is more complicated, you need more experience, but the R0 rate is much higher, and it is nowadays also a very safe technique. Indications for early gastric cancer endoscopic resection, according to the Japanese classification, as we can see, they are very radical. They even do, as you can see in the Japanese publication, sometimes a circumferential total submucosal dissection. Yeah. In Germany, it is a bit different. Actually, everything what is above more than 2 centimeters or ulcerated and or underlying histologies of diffuse type, then a surgery is recommended, but not endoscopic resection. So endoscopic resection is very limited. In Germany, the indications for these depends on the experience of the different disciplines involved, and especially the endoscopy who is undertaking this procedure. This I already mentioned, why we should not do endoscopic resection for submucosal invasion more than SM1, because it is correlated with a higher rate of lymphatic invasion, lymph node invasion. So EMR and EST both are very well documented in terms of survival benefit. Here, the data are coming from Southeast Asia, Taiwan, Japan, and South Korea. You can see that in early cancer, EMR is as well good as the resective procedures with an excellent survival and also an excellent disease-free survival. The same goes for EST. Here, we have also an excellent survival and even a higher rate of R0 resection with almost below 1% local recurrence rate. But we have to be careful. These are data from very specific areas in the world where the expertise is very high because of the total incidence of this disease in that specific areas. We cannot match this data, these results within, at least in European countries. So for every other type of cancer, more than S11, surgery is recommended, and there are various types of guidelines available even within Europe. First of all the different countries will have different guidelines, and also some specific societies are very curious to publish their own guidelines, whatever the motivation may be. And you will see as we go through the next few slides that although all these guidelines from the different countries, including Canada and USA, and the societies are based on the same literature available, they have different recommendations to take. So here you can see the time of first publication of national guidelines in Germany, almost 10 years back now. And accordingly, all other countries have also published their guidelines. Of course, in Japan, we had these guidelines much earlier. So we have nowadays a perioperative approach advocated in upper GI surgery, especially in gastric cancer. But you can see that although all these guidelines are based on same data, they have different indications for different stage tumors. Like in Germany, we would do perioperative chemotherapy only for T3 and plus disease, but the ESMO, the European Medical Oncology Society, for example, advocates systemic chemotherapy in all tumors higher than T1 grade. And here I have listed the available data that are the basis for these recommendations. And as you can see, what I have already mentioned, in each country, you have the same basis, because these are the publications that built up the platform to develop these guidelines. Now, in total, they are, for my opinion, and what the references are given into German national guidelines, there are 3 trials that are the basis for the advocation of perioperative chemotherapy in gastric cancer. First of all, it is the MAGIC trial, then the ACCORD trial, and a German EORTC trial that was terminated because of poor inclusion. And the first 2 trials, they have been published very well a long time ago, and they claim to have a survival benefit of 13 to 14% with the perioperative chemotherapy. I have to say, and we will see that on the next few slides in depth, that these trials, from a surgical point of view, are very, very poor trials, especially the MAGIC trial, where not even a proper staging was required, and for 1/3 to 1/4 of the patient, not even a post-operative histology is available and published. The ACCORD trial was initially a esophageal cancer trial, and after 3 years, because of the poor recruitment, they decided to include gastric cancer as well. But in contrast, the German EORTC trial, it was a very well-designed trial, and many surgeons were involved there. Inclusion criteria were very tight, and it was required to have high-quality surgery, like D2 dissection was must to be undertaken, complete staging was necessary, and histological reporting had also specific points to follow and report for further sub-analysis of the patient's data. And according to this tight recommendations and inclusion criteria, this trial was not very successful, and it was terminated after 7 years. But this trial showed that there is no benefit of perioperative chemotherapy, and it is as good, the surgery alone is as good as the perioperative chemotherapy. The MAGIC trial, published in New England Journal of Medicine 2006, showed that there is a 13% survival benefit compared to surgery alone. The perioperative chemotherapy regime was ECF. And the problem with this trial, I have already mentioned few, were many. But the main problems were that 1/4 of the patients didn't even have gastric cancer. And the tumor staging was undefined. 1/3 of the patients didn't have a staging at all, pre-operative or pre-treatment. No restaging was done after the systemic perioperative therapy. And as I already mentioned, 1/3 to 1/4 of the patient didn't even have a T or N staging after the treatment. The resection status was not even mentioned in the histopathological workup. So the total histopathological workup was very poor. No surgical standards were defined. It was not necessarily required to do a D2 dissection. That is quite something we cannot understand, because if we recall the MRC trial that we will speak about in a minute, is coming from the UK. And of course, and only 40% of the patients did undergo a D2 dissection. Another point that is to be criticized in the MAGIC trial is that when the MAGIC trial was designed, it was designed to have a combined data analysis with another already ongoing trial from a Dutch group. That was the Femtex trial, and based on this combined data analysis, the calculated power of 90% initially of MAGIC trial was published. But during the course of time, the Femtex results were very poor in terms of perioperative chemotherapy, and that Dutch study was terminated and no longer available for inclusion into MAGIC trial. And that Femtex study showed that The surgical group was performing much better compared to the perioperative treated patients. Yeah, you had a survival of 30 months in the surgery arm versus 18 months in the preoperative treated chemotherapy arm. So that's why this trial was terminated, and finally the data were not included in the MAGIC trial. This was the reason that MAGIC trial had to redo the calculation and drop its initially quoted power of 90% to 80% only. The conclusion of the Femtex group from the Dutch group was they concluded there is no beneficial effect of perioperative Femtex therapy, which is part maybe due to the fact that the study was underpowered, but it was pre-timely terminated. In fact, it tended to be adverse, the advocated effect. The insufficient response on chemotherapy actually led to an increase of time between diagnosis and operation, that is for sure. And until large randomized trials prove otherwise, an adequate resection, R0 resection, which is the common approach till end of the 90s, with the removal of at least 15 lymph nodes without delays, the best treatment for operative gastric cancer. That was the conclusion from the Dutch group, which then did not allow to include this data into the MAGIC trial. The second main trial that builds the basis for the development of the recommendations of the national guidelines is the ACCORD trial. And this trial was initially designed to be an esophageal cancer trial. And due to poor recruitment, after 3 years, they decided to include gastric cancer and junction tumors as well. In this trial, you will see, which claims to have almost similar results like the MAGIC study, an advantage of 13 to 14% survival benefit in the treated arm compared to the surgery alone arm. Only 1/3 of the patient had received the protocol-based therapy. 2/3 of the patients did not even have a gastric tumor. They had a gastric junction tumor, and they did a sub-analysis for gastric cancer, which did not show any significant data or survival benefit for the pre-treatment. But still, this trial is included into the national guidelines. The last trial that is also mentioned in the national guidelines is the German EORTC trial. This trial was extremely well designed, but has to, unfortunately, to be terminated because of poor recruitment. And this trial showed that though it was terminated, when they analyzed the included patients, that preoperative treatment had no benefit at all over surgery. And this trial also showed something else, that with clearly defined surgical standards, you can reach an excellent outcome without any systemic chemotherapy in gastric cancer. To come just here to show again the results of the MAGIC trial and the ACCORD trial. Please notice the median survival in MAGIC trial is round about 2 years in the pre-treated arm, in patients who had undergone chemotherapy followed by surgery. Similar results were achieved in the ACCORD trial with the pre-treatment. But in the EORTC trial, we have a median survival of almost 5 years without any systemic therapy with surgery alone. When we talk about gastric cancer, we have to talk about lymphadenectomy. As you know, D2 lymphadenectomy is recommended for gastric cancer. Just to revise, the lesser and greater curvature of stomach harbors the D1 compartment. The D2 compartment includes everything from the pancreas upper edge towards to hiatus and the entire ligamento hepatoduodenale. Especially, I would like to point out station 12, because many surgeons do not dissect the ligament up to this point. But if you do term your dissection as D2 dissection, you have to go up to the liver hilum. And then D3 compartment is everything para-aortic and intra-aortic lymph nodes below, but this is not recommended. So in the past, there have been multiple lymphadenectomy trials, especially no randomized controlled trial has been published from Japan, South Korea, or Taiwan in terms for the significance of D2 dissection. But in Europe, there have been mainly two gastric cancer groups who have addressed this issue, and both in the 90s. The first group was the Dutch gastric cancer group trial, and it compared D1 to D2 dissection. All patients did undergo only surgery, and only the different lymphadenectomy approach was here compared. This trial initially also in terms of sub-analysis of the various nodal groups did not show any benefit for D2 dissection. In contrast, it was even associated with a higher mortality and morbidity. We have to recall that up to the late 90s, D2 dissection was often combined with splenectomy and distal pancreatic resection. This was very commonly done, and this was also the case here. We will talk about this significance in a minute. The other trial that was performed almost at the same time was from UK, from Medical Research Council, and it was also a randomized controlled trial. Also, again, only surgically treated gastric cancer patients comparing D1 to D2 dissection, and it had almost the same result initially. The D2 dissection was associated with higher mortality and morbidity. In the sub-analysis, however, it was shown that patients who had a D2 dissection without a distal pancreatectomy and splenectomy performed very well, and they had a significant better outcome and a survival benefit compared to all D1 and D2 group who had a splenectomy and distal pancreatectomy. So it was not mainly associated with the dissection, the higher mortality or the non-significant outcome of these two dissection group, but may probably associated with management of pancreatic fistula or other complications. The Dutch trial did a 16 years follow-up of its initial trial and was able to show that in the D2 group, we have a significant survival benefit in terms of gastric cancer-related death. And in line with this, we had a local recurrence that was much lower in the D2 group compared to the D1 group. However, the 15-year overall survival was still comparable. After both these trials and other English trial was published, it was a prospective study and randomized according to the post-box number in that region. So very well randomized. And finally, it was proven in that study that D2 dissection has a survival benefit with an overall survival benefit of 60% almost in the D2 group when compared to only 32 in the D1 group. Yeah. And the extent of lymphadenectomy was beneficial for the patients undergoing a D2 dissection. An extended lymphadenectomy, this data comes from Japan, published in New England Journal of Medicine, means everything more than D2 does not seem to have an additional benefit because D2 dissection and in addition para-aortic lymph node dissection seem in this randomized control trial did not show any survival benefit in both groups. So from this, all these trials is to summarize that nowadays the D2 dissection is mandatory for gastric cancer resection. I have already pointed out that the MAGIC and ACCORD trial are the main trials that build the basis for developing the recommendations of the multimodal approach and promoting perioperative chemotherapy. Here, once again, I would like you to focus on the median survival in the treated arms. It is almost 2 years or a little bit more than 2 years. And please compare this with the lymphadenectomy studies published in the UK, the IRC trial, and the Dutch study from the 90s, where all patients had undergone not only surgical therapy, but they did not even have adjuvant chemotherapy. So they were not pre-treated and they were not treated after the surgery. And the median trial in Dutch study was about 4 years. And in the MRC trial, the long follow-up, it was a little bit less than 4 years. Almost double what the MAGIC and ACCORD trials do show now. Then often the argument from the oncologists is that patients after gastrectomy do not do well and do not qualify for adjuvant chemotherapy, and that's why the perioperative therapy approach is justified. This study shows it is an adjuvant study. Femtex I have already mentioned. There were actually 2 Femtex trials, just the difference was the addition of adriamycin in one of the trials. And this is analysis of the both prospective randomized trials in the adjuvant setting. And here you can see that compared to surgery alone, the adjuvant treatment in gastric cancer in 2 prospective randomized trials did not show any survival benefit between both arms. And with the surgery alone, as already the Dutch trial had shown, you can reach a median survival of 4 years almost, without any type of systemic chemotherapy. So the current standard in Germany, this is the latest perioperative trial that has been published 2 years back from my friend Albatran. He's very active, he's an oncologist, he's doing all the FLOT trials, and he published the results of the FLOT 4 trial in resectable disease, and he was able to show that FLOT is superior to ECX regime, and with this pre-treatment, median survival with the FLOT therapy can be achieved of about 4 years in gastric cancer patients who do undergo pre-treatment, surgery, and adjuvant treatment. And once again, we have seen this number somewhere else. Just to recall, I would like to show you these 3 graphs. If we take the Dutch trial, if we take the EORTC perioperative chemotherapy trial that was terminated in Germany, or if we take the adjuvant trial, Femtex and Femtex, in all these trials, without any systemic therapy in addition to surgery, and similar survival was achieved. Why? Because all these trials had clear definitions of surgical standards. Unlike the MAGIC trial, where it was practically left to you what you take out, it was clearly defined the extent of lymphadenectomy, the extent of gastric resection, and the histological workup. So, what does that mean? I don't want to demonize the systemic chemotherapy, but I believe that at present, we are over-treating many patients who do not truly benefit from the systemic chemotherapy. Our understanding of gastric cancer development and progression has increased. We know a lot about the genetical basis, and in future, we cannot expect to have trials where we will have only surgery-only arms. But as a surgeon, we have to recall that there are particular standards, though, that are very necessary to follow in the treatment of gastric cancer surgery for the benefit of the patient. And in future, we will have trials based on randomization on the underlying genetical fingerprint rather than different therapy regimes. So within the next 10 years, we will have maybe different data. But at present, this slide considered as a summary, as an analytical summary of the available trials from a surgeon's perspective, do not justify for every patient systemic chemotherapy. That's my personal perspective, what I have reached after going all in depth through the literature available data, and this is what I proclaim. Well, at the end of the talk, I would just like to mention that multivisceral resection in gastric cancer was obsolete many, like 10 years ago, but we have reached a point, and also based on case series from surgical units where we were clearly able to show that extended resections, including spleen, distal pancreas, liver, and colon, we can achieve a very good result even with surgery alone. Of course, the complications rate according to the extent of the surgery is higher, but this is justified because when we achieve an R0 resection, we have in almost 30 to 40% of the patients of 5-year survival in a metastatic setting. Survival of multi-resection in gastric cancer is again flawed data coming from Germany, from Albert Tran, who was able to show that in this scenario, the justification for perioperative chemotherapy is different. We have patients who are not metastasized. They have just a located tumor. They have excellent survival with the pre-treatment also. Yeah. I don't want to elaborate again the discussion on the effect of surgery or the chemotherapy in this arm, but he could show that in the arm with a limited metastatic disease, yeah, a pre-treatment, when these patients undergo surgery afterwards, a median survival of almost 3 years can be achieved. So my personal take-home message for you all is, do not compromise on surgical standards and quality of surgeries. It is very important to understand the various anatomical features. When you talk about the junction tumors or the gastric tumor, the gastric has a serosa, gastric junction tumors don't have a serosa, so they behave differently. And with this, I would like to come to the end of my talk, and I hope I was able to outline my critical points and my issues with the current advocation of systemic chemotherapy, especially pre and post-operative in gastric cancer surgeries. I'm happy to take questions, and I hope I was able to outline my issues.
Thank you. Thank you so much. I guess that was, as usual, very interesting and the deliberations were really marvelous. You have really touched upon all the trials and made things very clear. In fact, most often than not in, Asian countries, probably going for an upfront surgery followed by adjuvant therapy was, and probably is also in this part of the world, was a thing that people were following. But now, after maybe a decade back or 7-8 years back, things have really changing over here also. Our approach to a patient of gastric cancer is changing. The addition of neoadjuvant treatment is surely coming up, which was not there quite maybe a few years back. So how is, we get quite often more of locally advanced gastric cancer. So how is your practice? You get more of locally advanced, or you get more of early gastric cancer in Germany?
The overall incidence is quite low, but when we see patients, and if they are, in majority of the cases, they are locally advanced. So means you see on the CT that they are likely to have lymph node metastasis, or the tumor is infiltrating the liver or the colon. Yeah. And because we don't have active surveillance in gastric cancer, unlike in Japan, there everyone is going for active surveillance, and for the gastric cancer, everyone is screened for gastric cancer. They are looking actively for the cancer. Here, we only see patients who have been symptomatic due to the disease, and then they come to the clinic. And in that scenario, of course, you are too late. At least the tumor is larger. That's why also the experience in terms of endoscopic resection, because we are not actively screening, we are not seeing so many cases cases of early cancer here. These are is different from Japan or Taiwan or South Korea. I don't know about India. What's the incidence of gastric cancer in India?
Mhm. And the Indian, I mean, the incidence is not very low here. We get quite a good number of cases. In fact, many surgeons in the forum also, they will agree that we get good number of cases, but they are all mostly they're locally advanced. Many of them they present with obstruction. So they're mostly T3, T4 tumors, and these tumors, what I mean to say, were with the people, we had a tendency of going upfront surgery and followed by adjuvant therapy. Now that trend is surely changing. I mean, we are surely considering T3, T4 tumors, proximal tumors, nodal involvement, after even cross-sectional imaging, endo-ultrasonography, or a diagnostic laparoscopy with a fluid cytology and all. Things are changing. The neoadjuvant is coming up in a big way in this country as well. So I think, what's your perspective of what's the percentage of cases of if you compare gastric cancer with esophageal cancer? I mean, what's the more incidences of which one is higher in your practice there?
In terms of at the time of diagnosis, or
yeah, at the time of diagnosis, no, and about the junction tumors as well.
The junction tumors have picked up very much over the last 2 decades here. Yeah, that is available, the data in literature, that adenocarcinoma of the esophagus and the junction tumors are picking up. I recall the early data analysis from my residency time. I had in my data sheets almost 50% squamous cell of the esophagus and 50% adenocarcinoma. But now it's almost 80 to 20, the ratio. And the gastric cancer incidence in total is very low in Germany. It is not very high. But I would like to come back to your point that neoadjuvant is picking up. I think, again, it is, or let it put it other way. I mean, Japan has, over the last 3 decades, doing excellent surgery and has put the patients post-operative in oral S100. That was, I think it's an oral capecitabine drug. So they were doing excellent and they have excellent results. We still can't compare with these results. If you recall that the survival graph from the extended lymphadenectomy trial, you could see that the median was not even reached at the end. So it was still almost, the median was not even reached, and the patients had excellent survival. And these were not cases of early cancer. On the other hand, maybe that's often the argument in European countries. It may have a different biology. And that's why I brought up this genetic fingerprint. We have now a more in-depth knowledge about the underlying molecular and genetic alterations and fingerprints of the various type of tumors. It's not intestinal and diffuse only, as you can see in the literature now. And in future, the trials will be based on these genetic analysis. And that's why I also think that what we see right now, that the total, the complete response rate is about 1/3 to 1/4 in the patients who undergo complete therapy regimen in this perioperative setting.
Okay. So in fact, right from the word go, when you entered into this practice scenario, you are all your, I mean, how much percentage of your patients of gastric cancer you consider that upfront surgery also is feasible, or you make them subject everybody to a perioperative chemotherapy? I mean, you institute neoadjuvant, then surgery, and followed by adjuvant, is it?
Yeah, that's, I mean, the patient has to undergo through the MDT here, probably the same at your institution as well, or in India in general. You are not alone left with the patients. You have to discuss them within the board, with the radiologist, with the radiation guy, with the oncologist. And then they, of course, the oncologists, they call for the national guidelines, and there it is stated every tumor larger than T2 or node positive into the CT or EUS finding has or should undergo preoperative treatment. Then in my case, I do a very specific and individualized therapy approach. I look at the patient if he's eligible to sustain the perioperative therapy regimen. Now, FLOT is the primary systemic therapy protocol in Germany, and FLOT is quite aggressive. There are 40% grade 3, 4 adverse effects with the perioperative chemotherapy, and if you have a patient age of 75, 80 cannot undergo a FLOT treatment, and because he may not even qualify for surgery afterwards. And the total benefit, as I did show you, is in MAGIC and ACCORD trial, which should not be taken as evidence data for gastric cancer from my point of view, from what I understand and read and analyze the papers, because these are not qualified randomized trials to represent gastric cancer treatment.
Okay, great. So I think we can take a few questions from the chat box. There is a question from Dr. Suraj. The median survival between ACCORD and MAGIC can't be compared to MRC and D2 trials, since the inclusion of cancer is not same. There were more gastroesophageal junction cancers in the first set of trials who are expected to do worse compared to pure gastric cancers.
That's what it's absolutely right. That's what I tried to outline, that these trials do not qualify. If you say this, and I'm totally in line with you, and I'm totally with you. But then, as a second sentence, you should also add that these two trials do not justify perioperative treatment, because these data simply don't show it. And for the ACCORD trial, I mean, it is written, it is stated, it's published, the gastric cancer sub-analysis cohort in that trial did not benefit from the pre-treatment.
So do you still consider there is a gray zone in the perioperative chemotherapy?
Yeah, of course.
Yeah,
I do.
Yeah. Okay.
I mean, you see, stomach anatomical wise, it has a serosa. It is like colon. Yeah. Would you do a preoperative therapy for T3 N0 colonic cancer?
Okay.
You would not. You would not pre-treat it. You would even do adjuvant treatment if you don't have additional parameters, risk parameters. So, but the junction, as I pointed out, it does not have a serosa. It is different. There we have a different scenario. That's why accuracy of staging is very important. And there we have, or we don't have any reliable tool. With the introduction of endoscopic ultrasound, it was, we thought that we will have good data, but our own data from University of Hamburg, I published that in the endoscopy, showed that it is as good as flipping a coin. Yeah. And 40% of the patients were overstaged, means they did not have a nodal disease or did not have a T3 tumor.
So, I mean, in your scenario, diagnostic laparoscopy must be undertaken probably for every patient of CS stomach that you undertake surgery. Am I right?
Yes, I do it.
Yeah. So
yeah.
How, and you do peritoneal fluid cytology for all your cases? No. So in those cases where you do not have any radiological evidences of metastasis, and in those cases probably you choose for a peritoneal fluid cytology. Am I right, or is your protocol something different?
Well, actually,
imaging and EUS not showing any mets, you subject them for
I personally don't do any fluid cytological analysis. Yeah.
Okay.
Because if macroscopic in the laparoscopy limited peritoneal feeding is visible, then I would, if the patient qualifies for this, I would direct him to the oncologist and advocate a FLOT treatment.
Okay,
because
so you rely on your naked eye appearance of a peritoneal seedling, and if you find one, then you abandon surgery for chemotherapy. Is that right?
initially,
Yeah,
in the initial phase, yeah, in the initial phase, yeah.
okay. So I mean, peritoneal fluid cytology you do not practice on a routine protocol.
No, no.
Okay. So do you have any other protocol that I mean, you choose those cases that these cases need to undergo a peritoneal fluid cytology before I undertake surgery?
Oh, to be honest, I can't even recall when I did it last time.
Okay.
Yeah.
Okay. So it's more of a theoretical.
Yeah.
Yeah. Okay. Great.
Because the peritoneal cytological sensitivity, without knowing the exact number, I can't imagine that it is as high as EOS or any other available diagnostic tool. Yeah.
Okay.
Are you doing it routinely?
No, not at all. Not at all on a routine.
Yeah.
Not at all on a routine. But sometime we attempt doing it in those select group of cases where we find probably there is no cross-sectional imaging, not showing any mets, and even US not showing any distant spread or nodal enlargement. Some cases, it's absolutely not a routine, and
Yeah.
very selective. So that's why I just wanted to know what's your practice there. I mean, you do it routine or it's just okay. I got it.
Yeah.
Okay. So Dr. Bigyan asks how you actually follow up cases following a EMR or a EST. Is the EMR EST done in your institution itself, Yogesh?
Yes, it is done.
Okay.
And I had the luck to work with Professor Sohendra at the UKE for a long time. At that institute, it's an endoscopic institution. They are doing EMR, EST almost every day. So we are not following them up. So that is the patients do belong to the gastroenterologist. So they do have a follow-up. But from what I know is that after EST, they do a re-endoscopy within 3 months.
Okay. So every 3 months they follow them up. Okay.
Yeah.
And please go ahead.
Yeah, and then of course there's a very close communication in those cases where the histological does not prove to be objectively R0 resection, and the patient is especially young. I mean, it's different. If you have a 75-year-old guy, you do an unclear R0 resection, or it is not clear that you have clear resection margins after EST. In EST, if you have a good endoscopist, you have high rates of R0 resection. But like few are doing EMR, then you are unsure about with the piecemeal and the resection margins. Then in those cases, we do a follow-up in the elder patients, but in the younger, not to put them on risk, we would address them to surgery.
Okay, so his next question is about the incidence of maybe early gastric cancer. That's to me, but in fact, I have never probably ever seen an early gastric cancer till now. Whatever I have encountered, those are all locally advanced or with metastasis. So hardly ever. How is your practice over there in US? How often you encounter early gastric cancers?
I can recall that I have never published that paper, but when I was at UKE, I had data collection over 3 years of 19 patients who had undergone ESD. Yeah, so it's not much.
Not much. Okay.
That's why I also pointed out in my first few slides that these data with EMR and ESD showing excellent results, but we have to be very, very cautious. You cannot send the patient with T1 gastric cancer to the local endoscopist if he does not have the expertise to do a good EST, reliable EST. Then you are putting him in on risk.
Okay. Next question from Dr. Suraj is about the FLOT trial. I think the trial showed good evidence promoting peri-op chemo, but concerns are which patient may respond well to FLOT. How do you assess the response after a few cycles? Because in Indian scenario, concerns are about the safety and tolerability. And in Indian scenario, probably another concern is patient follow-up as well, because many of our patients, even a neoadjuvant treatment, they think that the treatment has given them good result. They are now able to eat, and they just forget for surgery as well. So that's also again another concern for us. Yeah.
For those who I put on flood trial, or because I sent to my oncologist for flood trial, we do a restaging after the second cycle. And if the patient is tolerating, because flood is really an aggressive chemotherapy regimen, we should not forget about that. It has become better, but also with the experience of the oncologist, but still it is aggressive. And if the patient is tolerating the flood regime, we do a restaging with CT after the second cycle. And if it shows stable disease, or at least no progression, then we would like to continue the pre-treatment. It's actually 4 cycles pre-treatment, and then we would address him to surgery.
Okay. There is another question from Dr. Tushar. What is your approach in patients when intraoperatively you find it having some mild tumor invasion to the head of the pancreas? Abandon or neoadjuvant and then surgery at a later setting?
You might distant as a metastasis, or just because it is locally infiltrating?
I mean, he means local infiltrating.
Yeah, if he has undergone, if I find it before crossing the line of no return, then I would abandon it, and then let it, and if the patient qualifies, I would have him undergo a preoperative therapy.
I think most of the cross-sectional imaging that show a local infiltration, in reality, when you enter in, you don't find that to be a concern at all. You can surely go ahead with surgery and followed it up with an adjuvant treatment. Rarely ever, in fact, I have ever encountered a local infiltration. I have abandoned the procedure, come back for a new adjuvant. Probably that is an overkill, more of an overkill.
That's true.
Yeah, because
the other scenario is you open up the belly and then you see you have a small liver met in the left lateral lobe. So in that cases, I do not abandon. I do the gastric, and I also take out the single metastasis in the liver.
True. What is the adjuvant therapy offered to patients with locally advanced gastric cancer in Germany?
Actually,
operated case. But so you rarely do an upfront surgery, Yogesh, am I right?
Open surgery?
Yeah, open. I mean, you probably never go for an upfront surgery. You go for a neoadjuvant followed by
No. I'm still going for half of the patients upfront surgery.
Upfront surgery, okay. That's in fact the practice here in India as well. I mean, majority patients probably they're going for upfront surgery. Now, of course, that tendency of going for neoadjuvant is surely picking up, but majority are also going for upfront surgery. Okay, fine. Please go on. Yeah.
Well, in gastric cancer, you don't have, in Europe at least, an adjuvant protocol. As I said, this FAPTEX trial, it is quite an old trial, but there are at present no available randomized controlled trials for the only adjuvant setting in gastric cancer. So what we do is, if we we have a young patient who has in the final histology a T3 tumor, then we discuss this in the MDT, and then he would receive a flood regime if he qualifies.
Okay.
Yeah.
Is S1 available in Germany?
I think it is available now. It was not for a very, very long time. It's very, very recently it has been available.
Okay. And
but I don't think it's really the oncologist to apply it.
Okay. The other question from Professor Saroj sir is, what is the recommendation for hereditary predisposition of gastric cancer cases in families to have surveillance screening to get the subset of early gastric cancer cases in Indian scenario? I mean, does your practice shows more of a familial incidence in gastric cancer that you encounter in your patients?
Oh, very few cases only. No, I don't know about you, but how many have you seen?
I haven't. Any. I mean, it's not that very common that we discuss. how much, Dr. Sahanabi, how much margin will you take in a proximal gastric cancer? Will it depend upon the pre-NACT CT scan or post-NACT CT?
That's an excellent question. So, so the recommendation for this is about 5 centimeters. Yeah. So, but if you consider the location of the tumor, sometimes you cannot go 5 centimeters up. So, what I do is, was it proximal or distal? The question was it regarding proximal?
Question is for proximal gastric cancer.
Yeah, proximal gastric. So, I would like to have like 3 centimeters if it is possible. Yeah.
Okay. But
so, but then I have, of course, a mediastinal anastomosis with esophagoileostomy.
Okay. And surely you'll be deciding this on the post NACT CCT.
Well, I mean, I decided on what I can feel within the at the intraoperative people. Yeah.
Okay. That's intraoperative feeling. Okay.
Yeah.
Fine. Okay.
But we do intraoperative fresh frozen.
Okay. Dr. Dinesh asks, what's the role of cytoreduction on HIPEC in gastric cancer?
Well, from all the indications, I would say that we have to be very careful for upper GI cytoreduction because the complication rate is very high.
Very high.
And from the data, I mean, I personally have experience of around about 80 debulking procedures and 35 to 40 HIPEC. And the gastric cases where probably the worst, and they did not benefit much because of but I think this is an issue of the complication rates they developed after the open surgery.
Okay. Okay.
And so, the only data, the true data we have for cytoreduction, the randomized trial is available for colorectal cancer.
Right, right. So what's your strategy when the malignancy infiltrates falciform ligament? Do you change any of your resection strategy in it?
No.
I don't think you don't. Nobody changes any resection strategy for infiltrating, right? No. And what about whether EUS you do it routinely for the T stage?
No.
Yeah, it's not routine.
It's not done routinely.
Yeah. Okay. Yeah. If you find 16B1 positive during surgery, do you go for neoadjuvant?
No.
No.
Do you go?
No, no.
No. I mean, for my personal feeling, there are very few settings I would go. If a young patient, if I find peritoneal seedings at different places, not located within the region of the stomach and the surrounding area which I could block resected, then I could reconsider abandoning the surgery, terminating the initial step, and let the patient undergo flood regime and do the surgery afterwards.
Okay. I guess what's your practice of molecular markers? Do you routinely do it?
No. In clinical setting, we don't do any.
We don't do it. Okay, fine. I think.
So some patients, I have seen some people doing routinely tumor markers for gastric cancer, but I don't know. For my understanding, there are not any truly reliable tumor markers for gastric cancer.
Right. So I think probably there is no further questions on anything on the chat box. We have really covered. That was a wonderful discussion. I guess it was a fabulous presentation. You have really touched upon every aspect of all the trials that you made things very simple. But we need to boil down to the fact that probably neoadjuvant treatment we'll consider for those T3, T4 tumors, proximal tumors, nodal basins, involved nodal basins, and going for surgery followed by adjuvant. And probably US is not routine. Diagnostic lab with is routine, but peritoneal fluid cytology is not routine.
No.
Yeah, I mean, So there are few take-home messages. But it was a fantastic evening spending with you. And
Same here.
so thank you very much, Vegas. It was
Thank you, Manoj.
it was a brilliant time we spent. Thank you very much. Looking forward to meet you again. And
Thank
thank you,
you.
everybody. Thanks, everybody. And namaste.
Thank
all.
you.
Thank you.
Bye-bye.
Stay safe. Bye-bye.
Thank you.
Yes.
Namaste.
Bye-bye.
Bye-bye.
Bye-bye. Bye.